Good afternoon, everyone. Dr. Ara Dugmajian here, and we're at Duke Spine Institute, getting ready to do a Duke laser disc repair. Left approach, L45. Our patient has a very large disc extrusion, is what it appears to be, at left L45 in the foramen and extraforaminal. So that's what we're going to hopefully remove today. Thank you. You need me to turn you?
No.
You haven't turned yet. Okay, we're going to get started. Are you awake?
Are you awake? Yeah.
All right, Dr. Duke here. We're going to get started, okay?
I talked to him.
The first thing you're going to feel is a little stick and burn, and that's just the numbing medicine going in. All right? So don't be alarmed. Try not to move. All right, I'm sorry about that. That's the worst part. Blood pressure? You getting it down?
Yep.
All right. So we like to keep our blood pressure down. Is that better now?
You see better? Yeah.
Just let me know if you feel any discomfort, okay? I'll give you some more numbing medicine. Shot? All right, give me a lateral, please. You're doing great. Everything's okay. I'll let you know if we have any issues.
John. You see the suction? Make sure it's on the other side.
Okay. All right, so we know that there's a pseudo disc at 5-1, and then we know we got 4-5 and then 3-4. So let's look at the MRI. So it's easy to get kind of confused when you're dealing with the spine if you're not 100% sure where your level is. So 5-1 looks very straight, but it's a full-size disc. It appears to be a full-size disc on that MRI. So I'm going to look for a straight segment full-size disc. I feel that that's it right there. That would bring 4-5 right at the iliac crest, pretty much where we're headed. So I think we're heading to the right direction. Shot. I may want to change my trajectory. I want to see how I approach the foramen. Shot. Shot. Is that bothering you? Shot. Let's give a little more numbing medicine. Leave it.
Are we good with the irrigation, John? Okay, yeah. I'm open to. Perfect.
So the first step here is to get down to the foramen. Shot. And are you lined up at 4-5 good? I think that's pretty good actually, Jordan. I'm pretty happy with that. Tell me if you're feeling discomfort, Shot. Is that uncomfortable for you, sir? Shot. Everything's going well so far. Shot. Give me an AP, please. Now, there is another disc down below. You guys can kind of make it out, but we call it a sacralized L5S1, meaning that it's actually fused to the sacrum. Yeah, that looks good. Let's go back to a lateral. So this patient has a sacralized L5S1, which is not mobile, so it will never herniate. And then he's got the 4-5, which is the first mobile disc. And that's where we're headed. All right. Let's try to get a better lateral. See, your iliac wings are not lined up. So let's wag a little bit, pick one way or the other, and let's see what happens. 2 degrees, Shot. That is better, for sure. So let's just leave that. But you're too far south. Shot. Shot. All right, so now what you're gonna need to do is you're gonna need to go further north. And which way did you wag my side? South? So go a little bit more north, lock it, and then wag my side south. About 5 degrees or 6 degrees. Yeah, that's good. Now we can get those iliac crests a little bit better. Let's try a little more wag. Maybe we over wagged it or under wagged it. Try a little more wag. Shot. All right, go back 4 degrees or 5 degrees. We over wagged it. That's pretty darn good. I like that. That's really good. All right, let's leave it there. Lock it down. All right. Let me know if you feel any discomfort. Shot. Are you feeling anything, sir? Where do you feel it? Just your back? Anywhere else? Shot. I'm sorry about that. AP? That's what's been bothering you, right? We found it. Little fentanyl. Little fentanyl. Or you can put them under. You can start putting them down. All right, so where did you feel that? In your back? Same place? Shot. So pretty lateral. Just wait a second. Wait a second. Let me make sure a discogram looks good. Shot. All right. Yeah, big herniation there. But we're definitely in the disc, so I like that. All right, you can go ahead and put him to sleep. How bad is that on a scale of 1 to 10? A 40? All right. Just lay still. Everything's okay. Shot. I can't see. All right. When you wake up, we'll be done. So, for anybody who wonders whether or not a disc herniation hurts, I don't wonder. I don't think Luis wonders. I don't think anybody here wonders. We all know disc herniations can cause horrible back pain and leg pain. Tell me when he's asleep. Let me know when I can proceed. Proceed? All right.
We have a question.
Sure.
We have a viewer asking, do you always do a discogram prior to doing each surgery?
So the question is, do I always do a discogram prior to doing each surgery? Great question. So the answer is the discogram is actually part of the surgery. It's a part of the Duke laser disc repair. So we do it 100% of the time. Yeah. We do it 100% of the time. And the reason we do it is, number one, to make sure I'm in the disc. Number two, to see if the disc is painful. Number 3, to stain the nuclear material or the herniation blue so I can take it out easier. And number 4, we need to be in the disc to be able to do the surgery properly. So there's a lot of reasons for me to do the discogram, but I do it every single time. Yeah, absolutely. Shot. That's it right there. All right, so this patient has a massive disc herniation, I can just tell you that, and it's shot out really far lateral. So I haven't taken out a lot like this because they're not that common. So this is going to be a really interesting experience for me as well as a surgeon, because shot. It's not common to have that big of a disc herniation laterally. That's it there?
Yes, sir.
Give me an AP. So to answer the question though, a discogram is done with every surgery. So it's actually part of the Duke laser disc repair. When you do something every single time the same, that part of what you do is always usually included in the surgery. All right, so I think we're up against the herniation. Let's go back to a lateral. Monica, any way you can show me an axial view on that? And keep the AP on the monitor. I want a lateral shot. All right, so I am still a little bit away from the disc, which you could see on the other view, but I am coming up against something and it feels like the herniation. I'm going to try to advance a little bit more shot. Now I'm kind of right at the disc, and let me get another shot. So let's get an AP. So this part of the surgery is called navigating. And what we're navigating is we're navigating our instrument down to where it needs to be to do the surgery. And to me, this is the part of the surgery that has to be done just perfectly right. So I feel like we're a little bit lateral to where I want to be. But the guide wire goes to where I want it to be. And I feel like I feel the herniation. If you look there, we're kind of at the back of the disc. And the lateral view shows we're at the back of the disc. Shot. Yeah, lateral view. So we're kind of at the back of the disc. That's what we're seeing there. Shot. Give me an AP. And that looks like we're inside the disc. Let's go ahead and take the scope down.
You wanna
Lateral. How's he doing? Good. Thank you. Is that it?
current shot, yes, sir.
Shot. Is he comfortable? Shot? Alright, that's good. No, it's already out. Shot? So we're definitely in. Flow out. This is again L45. I'm calling the disc below L5S1. It's a full-size disc front to back, but it's really not a true disc because it's not moving. And that's really, surgeons have to pay attention to those kind of things because they can end up being lost in the spine. But I feel very confident we're at the correct level. Why don't you go over there and help her make sure. Let's just take a peek. There's a herniation right there. Alright, so if we're lucky, we'll be able to get this thing out in a couple of big pieces, but I'm not counting on it, to be honest with you. That's a big piece. I think that may be the offender, the major offender, but we're going to look. That thing is really...
Suction is working. Alright.
We seem to be a bit overexposed.
You can turn off these lights and turn the X-ray lights, please. Yes. Laser, sir?
I know, I need a grabber.
Yes, sir.
I'm hoping this thing's going to come out. Do we have a larger grabber?
We have a budget. It's back there on the right. Right here? Yes.
Just have it ready. I'd like to tease this thing out rather than take it out piecemeal. But it's not wanting to come out at one time.
That's okay, Monica. We're gonna use the laser soon. So.
Let me have a bigger grabber. You have it or not?
I don't
No.
know.
Laser.
Oh, Monica, we need it right now. Monica.
Let me have the grabber again.
Yes, sir.
All right. Once again, I'm Dr. Duke Majin, and this is Duke Spine Institute, Surgery Center of Viera. And we are performing a Duke laser disc repair. Oh, yeah, that's a big one. Did you find a bigger grabber? Jordan's grabbing the grabber?
Yes.
All right. I'm trying to tease it out, but it's still breaking off into pieces. It's nice when you can get the whole thing to slide out all in one.
I mean, the teeth has to be larger. This right here and this rack over here on the top, there's multiple grabbers I put it there. Right here. Right there. Suction are working, Joe? I don't hear them.
Let me know when you're ready with the laser.
We are ready.
No, like suction is on and it's going in.
Okay, good.
Like I'm sucking fluid.
I'll take the laser.
Monica, that's ready? I don't see the light. I don't see the light. Ready?
Targeting beam. Why don't you go over there and help her out? What is it? No, no, pedal's fine. Thanks. Are you on 30?
I'm on 30.
Ready?
What is it?
Ready. Good.
Hey, that's working.
All right. Thank you.
Yeah.
Every time you get out.
I mean, look at that thing. That's a big chunk right there. It's just moving. Standby laser. The standby is really just so that I don't accidentally step on the pedal and zap Luis in the eye. Like Star Wars, you know, with the lasers shooting around.
He appreciates that.
Yeah.
I just can't grab
Maybe
this
fix
thing.
my vision because I'm blind.
You're going blind?
Yeah.
You know what they say.
We have a question.
Sure, Zach.
We have a viewer asking, what can cause an infection after having a microdiscectomy, and is there anything that can be done to prevent it?
So somebody says, what can cause an infection after a microdiscectomy? Is there anything that can be done to prevent it? Yeah, you know, it's a great question. Microdiscectomy, for those of you who don't know, is a surgery of the spine. Luis, I can't twist this. Is a surgery done on the spine where some of the bone is taken out. I can't twist this.
Let me
Come on.
Mike, I need you to bump these with the machine.
It's a procedure where the bone is taken out. They do a laminectomy, and this is just stuck down.
Now, better?
Not much, just a little bit, but anyway, infections are I just cannot get it to swing. What is going on? It's not rotating. Standby. Got to get that working. I don't know what you guys are doing different. Infections are just, unfortunately, there's nothing the surgeon does necessarily to make it happen. It's just bad luck. It's also operative technique, antibiotics, how clean the instruments are. You can have dirty instruments. You can have a dirty patient. You can have, you know, bacteria in the blood from problems with the teeth. There's just literally 100 things that could cause infections. Smoking, diabetes out of control. So it's not unique to the microdiscectomies. But that being said, with this surgery that we're doing right now, we've never had an infection. Never. And we've done 1,000 of these surgeries. So the reason why these surgeries don't get infections is the place that we do it is very clean. That's better. What'd you do different?
I just called him.
Yeah, so a clean facility. We don't put any implants in here. We're not removing any bone. We're literally just zapping the disc away in the annular tear. So we also have a very clean facility. We use antibiotics in the irrigation. You see all that water going around down there? That has antibiotics in it. We also give the patient antibiotics in their vein called IV antibiotics. So there's a lot of things that we do at Duke Spine that kind of, we take the best practices that everyone uses and we put them all together, and because of that we haven't had any infections. But infections are very common, unfortunately, especially in the hospital setting. People having surgery in the hospital, because hospitals are where people with infections go. So it's very likely to spread from one patient to another at the hospital. I hate to say it, but that's the truth. So there's just a lot of variables. You can't blame it on one thing. You can't say it was a surgeon or it was dirty instruments. There's a lot of different reasons people get infections. Also, how long the surgery took, how much of a blood clot the surgeon left in there. That's important too. Did he leave a big blood clot? A little blood clot? Big blood clots more likely to have an infection. Little blood clot less likely. There's just a lot of variables. All right, standby laser. Let's see if I can grab that out. It's a great question, though. It's one that I can tell you doctors and hospitals and nurses have been dealing with for hundreds of years. Like, how do you prevent these infections from happening, right? And they have whole meetings every week with the infection committee. You have infection control officers. You have pharmacists meeting with doctors, infectious disease doctors. Everyone's always trying to find ways to reduce the risk of infection from surgical procedures. So unfortunately, we have never been able to get it to zero, but Duke laser disc repair, the procedure you're watching right now, does have a zero infection history. We've had 0 infections.
We have another question.
Yeah.
We have a viewer asking, after you use the grabber, what exactly is the laser doing?
So the laser is freeing up the herniation. The grabber is taking the chunks out. The laser can't take the chunks out. The laser can only zap some tissue away. But to get the big chunks out, you need the grabber. And this patient has a big herniation. So I'm trying to get the big chunks out. But unfortunately, a lot of times herniation, look at that, stand by. Herniations, what happens is when the herniation comes out of the center, the nucleus gel sticks out, it hits the annulus, and what happens is, that's a big piece of herniation there. The annulus starts to scar down on it, like stick to it, basically. They stick together, right? And then it's like impossible to get the herniation out because it's stuck down to the annulus. The annulus isn't going anywhere unless you laser it out. So really, what we're dealing with is a situation where, that looks like a piece too. Yeah, that looks like a big piece right there. Give me the grabber. We're dealing with a situation where the herniation causes inflammation. The inflammation causes the herniation to stick. I think this is the main piece right there. That's huge. But I think there's still more. So, yeah, there's more. So the herniation basically causes inflammation to happen within the annulus. You guys understand what I'm saying? For those of you who have been around a little bit. Oh, that's huge. A lot of big pieces of herniation here. Hopefully we're getting it all and this poor patient can get some relief. I know he's been suffering for a while. I just may not be where I need to be to get it all out. So I'll keep trying to get in the right position. Take. Well, you thought I was going to grab you with the grabber there, Luis? You're too funny, man. So hopefully I answered the questions that people are asking. I try my best to answer them, but sometimes I misunderstand the question. I just do my best. Yeah. Oh yeah, there's still more here. Stand by. This is all herniation. Ooh, that's a big one. Look at that thing. Whoa! There's almost a sucking sound. It's so huge. Oh. Look at that guy. You see that, Zach?
We can see it.
Alright, that's
A little
big.
bright.
That was like half a grape right there. There's another one. Yeah. Wow. You got to see this guy. You see this? Can you see it or not?
We can see it.
All right. Big herniations. Big. So Luis, show it to them at the end of the case. We'll show you a little pile. All right. So, who has a question? Like a real question or?
Like, no, like a serious question. So you did a patient a month or so ago. You did a Viera and then had to do the microdiscectomy on.
Yeah.
Why
Grab
did
her.
you not go back in? I thought you had to do the microdiscectomy because of the size of the herniation.
No, I didn't. So we had a question who says that you had to do a microdiscectomy on a patient a month ago. Luis, you're not cleaning this out. You got to get inside there. So the question was, Dr. Duke, why did you do a microdiscectomy on a patient a month ago when I did a microdiscectomy? I thought you don't like them. And the answer is I hate doing microdiscectomies because they're bad. Because you have to drill away bone. And I took away as little bone as I could, but I still had to take away some bone. Right? So why did I do a microdiscectomy? I thought it was because the disc herniation was too big. No, it wasn't because the disc herniation was too big. It was because the disc herniation had migrated down. It went down like out of the disc, and instead of being in the foramen where I always get them, it went like south towards the feet. And it got stuck behind a piece of bone that's already there. And that piece of bone is called the pedicle. And I can't go through the pedicle to get the herniation.
I need it right now.
What do you need?
More basics.
So we're actually looking, quite interestingly, we're looking at we're outside the disc and we're looking at the surface of the disc right now from the foramen. So the disc is right in here. I'm kind of grabbing any free fragments I can get. The epidural space is up above at 12. And we're quite literally in the foramen. The nerve root will be right up here. See the nerve root right there? That white thing at 9 o'clock? Hey, that's the nerve. And I think we got all the herniation out. I'm just going to clean it up a little bit. Let's call Dr. Patel. So that's the hole in the annulus that has to heal. And I want to make sure it heals properly. Why am I having trouble rotating this again? Oh, that's better.
We have a question.
Yeah.
We have a viewer who says, I have a herniated disc at L45, L5S1. Spoke to the doctor about surgery due to pain in the right
Hold
leg.
on a second. Hold on. Stand by. I want to put the dilator back in. Scope off. Dilator. Lateral fluoro.
Lights on, please.
Just give me a second, whoever's asking questions. Lateral fluoro. I want to get back in the disc just for a minute and clean the things up a little bit, and then we'll come back out again, check the foramen one more time, and we'll be done. So 10 minutes max. Let's get Patel here. Let's go, Jordan. Zip it along. All right, I'll take the question.
We have a viewer who says, I have a herniated disc at L45, L5S1. Spoke to the doctor about surgery due to pain in the right leg being severe. He recommended doing epidural injections because he says people live with herniated discs. I feel as though I'm wasting my time doing the injections. What would you recommend?
All right, so you have a herniated disc, and I think you have maybe back and leg pain, and you want to know, should I even do the injection shot? Correct? I think that's what you're asking.
Yeah, they said severe right leg pain.
I think you should, shot. I would do the injection. That's what I'd recommend to my patient. You should try at least one. Then you know you've done everything you could do besides surgery. And one epidural for leg pain is a very reasonable thing to do. I wouldn't do more than one if it doesn't work, but you should get at least 50% is the magic number. 50% of your pain should go away with the first epidural in order to do the second. If you don't get a 50% improvement, then I wouldn't do a second one. I go to surgery. Here. So, no, I don't think it's a waste of time. And it's a very low risk procedure as long as you have a good doctor doing it and they know what they're doing. It's very low risk to you, like almost no risk, but not zero, because there have been some issues with the medications in the past. And some doctors are terrible and they actually hit the nerve root accidentally. So there are things that get a CSF leak. There are things that can go wrong for sure. But I think if you can get it done safely, that an epidural is a very reasonable thing to do before you commit to a surgery. Okay? Laser.
Ready?
So I feel like we got most of the herniation out, if not all of it, and I think our patient's going to do well, but I'm a little bit concerned because it seems like there's still some area here that looks like it needs some help, like debridement, so it heals properly. I want to make sure this doesn't happen to the patient again. You can see some scar tissue forming. I want to clean this up a little bit. So I feel like I've gotten probably 80% of the giant chunks out, and we'll look at the foramen one more time, see if I can get any more. But we got some really big pieces out, and I'm going to have Luis show those to you in a minute. They're huge. And that certainly lines up with the MRI and what we saw in the MRI before surgery. So I feel like we got the offenders out. We found them and we got them out. But I need to clean the annulus up a little bit more so it heals properly, so this doesn't happen again. So I'm trying to debride the annulus right now so that it reduces the likelihood of this happening again. Right now I'm looking laterally. So this thing was really lateral. Yeah. So, you know, I'm sorry, I may disagree with you, but I would do the epidural. And if you're having any numbness or weakness, then I don't think you should do the epidural. If you have any weakness, I don't think you should do an epidural first. I would go straight to surgery. But if you're having just pain, I think an epidural is a reasonable thing to try. That's what we would do at Duke Spine at least. And that's because we know we can do the epidural safely. You know? If your doctor cannot do an epidural safely, then you shouldn't be doing an epidural with that doctor. I'm going to tell you why. That disc herniation that's causing your pain, it's causing your pain by inflammation. And what an epidural is the doctor is actually injecting an anti-inflammatory drug right into your area where your herniation is. We have medicine ready?
Yes, sir.
And that anti-inflammatory drug, there's nothing wrong with using that. It's actually good. It can target right where your inflammation is. Does that make sense? And by targeting your inflammation right where the source is at your herniation, that's actually good for you. It's better than taking that stuff by mouth and toxifying your body. I'm having a hard time twisting again. How's our patient doing, Dr. Santoro?
Very good, sir. Very good.
Thank you. Thank you. Good job. We're almost done. I say 3 minutes. I'm almost done here immediately, and then I'm going to swing around and take a peek at the lateral foramen again and just make sure I didn't miss any fragments. There's the end plate of L5 to the right at 3 o'clock. And then, of course, the other end plate is right there. The epidural space is ahead at 12. So we're just going to look laterally here now and see what we've got. So I'm going to zap some of this material away. It's all bulging disc.
We have another question.
Sure.
We have a viewer asking, does the size of the herniation impact how difficult it is to do this surgery?
Does the size of the herniation impact how difficult it is to do the surgery? The answer is no. There's the nerve root, by the way, right there. Okay, so we're just below it. I don't see any herniation on it. I'm looking laterally. I don't see any more herniation. It all looks good. There's a little nub in there. No, the size does not, but the location does. And honestly, the bigger herniations just take longer to remove. So I like small herniations because I'm just being selfish, but it makes my job easier. Plus, it's safer for the patient, you know, to get rid of a small herniation. It's very quick and easy. And for the patient, they have a shorter surgery, right? And there's less risk for the patient because the bigger the herniation, the more likely it's pushing on nerves and other things, right? This is a very tiny space in here. You don't want anything big in here. So having a big herniation is not good. I feel pretty good. We looked in the foramen. I don't see anything more. I looked medially. All this is good. It's all healing nicely.
Stand by, lights off.
Let me just take a peek real quick, Luis. Hold on.
Yeah.
I just want to make sure I'm not leaving anything. Let me see the grabber. I don't think that's a herniation. I think that's just the annulus. Doesn't look like herniation to me. Yeah, I'm not getting anything. I think we got it. That's all stuck down. That's all supposed to be there. So, let me just, let's take a look at the nerve one more time. The nerve root's there. It looks a little inflamed, a little redness, and I just don't, I'm following it. I just don't see another, I don't see the herniation anymore. It's, I think we got it all. Let me just zap that tissue right there. By the way, what I'm doing right now, going lateral in the foramen, is like, this is only for doctors who have been doing this for a while. Getting a medial herniation is not a big deal. Going lateral is a lot harder. All right. I think that's it. I think that's it. I don't see anything else. I think it looks pretty good. All right. Stand by scope. Hopefully we did it. We'll see. The patient will know in recovery. Let's put those herniations up here so everyone can see what they look like.
We have a question.
Yeah.
We have a viewer asking, what's your opinion on using pregabalin to reduce inflammation from a compressed nerve?
Pregabalin?
Yes, sir.
I don't have an opinion on that. That's a great question. I don't even know that pregabalin reduces inflammation, does it? I mean, I thought that had more to do with like gabapentin, but that's not an anti-inflammatory. It's a nerve stabilizer. So I'm not sure what, I'm not familiar with pregabalin. All right, what else do we have?
No, we have more.
Let's go. Let's get the show on the road.
The other one are the smaller pieces.
Yeah, bring them all. Bring them all.
That's a sure.
All right, so can you guys see this here?
We can see it.
This is what we pulled out of his foramen, basically. And just to give you an idea, that's pretty big. Honestly, that's pretty big. Hi, how's it going? Where's my pickups? So this is the herniation right here that we just got out. And those are some good chunks. It looks like, you know, yeah, this looks like what we were looking at on the MRI. I think this is a lot. Hopefully that's it. We're done. But just the location of this herniation being in the foramen makes it really, really challenging. Okay, let's put that away. Good job, everybody. Let's see how he does. I'll take any more questions you have in the recovery area. Thank you. Good job. Thank you. Good work today. Thank you, Dr. Santoro. Will you let me know how he was recovering? I heard we have some special visitors. I'm going to go have a talk with them. How old are your kids? Oh, wow. Will they be scared if I poke my head in there? We have such amazing staff. They've stayed behind. It's Friday at 5 o'clock. They've stayed behind to get this done. Where's Patel? He's supposed to come and do the rhizotomy. All right, we need to get him over here. All right, I'll come talk to you all in a minute and answer any more questions you have. Give me just 2 minutes. they still see? Yeah, let's show them. All right, folks. So Dr. Duke Majan, CEO and founder of Duke Spine Institute here in Melbourne, Florida. And we take care of patients from all over the world. So when people say, do you take care of patients from out of state? Yes. Do you take care of patients who don't have insurance? Yes. Do you take care of patients with green skin and tentacles growing out of their head? Yes. And what you're watching right now, just so you know, is that's the incision on the patient's back, and we put a little bandage on there, but you can see how small that incision is. It's about 7 millimeters. So the entire surgery to fix the herniated disc is done with a 7 millimeter incision. It's the smallest incision there is to fix a herniated disc. And we didn't take any bone out of the patient's spine. So if you look off to the left of the picture, you see a line going down the middle. That's the midline. That's where most surgeons will go when they do this surgery, the microdiscectomy, okay? Yeah, thanks, Luis. And by going in the midline, you got to drill bone away, and that always weakens and destabilizes the spine. So when you have a incision like we do and a trajectory like we do, 45 degrees to the foramen, you can actually come in through a natural hole that's already there. So you don't have to remove any bone, you don't have to damage anything. The only damage we're causing is to the skin where we cut it. So you're dealing with a 7 millimeter scar, and that's it. The rest of the surgery is done without damaging anything. So it's pretty incredible surgery. I'm pretty happy with the results. I'm hoping this patient does well. You never know if you got all the herniation out until obviously the patient, gets awake and tells you if their leg pain is gone or their back pain's gone. But even then, you don't know if you got 100% out, and surgeons aren't going for 100%. What we're going for is really to cure the patient's symptoms and signs. So back pain, leg pain, numbness, tingling, and weakness. That's what we want to fix. And of course, we don't ever want it to come back. So our goal for surgery is not to make the disc look normal. It's not to make the disc bigger. It's not to do anything other than give the patient back the quality of life they want and the ability to do everything they want to do. So obviously, this is going to take time to heal. That disc that we just went into and took those fragments out, if this patient doesn't give it enough time to heal, it's going to come back again. He'll have another herniation. So some other piece from the middle will just pop out through that hole. So you've got to let the annular tear heal itself. We debrided it, we set it up so it would heal, but the patient has to behave, not lift anything heavy over 25 pounds, and don't do any bending at the waist. Any kind of bending at the waist or lifting over 25 pounds really dramatically increases the likelihood of having a recurrent disc herniation. All right, so I'm going to take the first question. Why is it that small herniations can sometimes cause more pain than big ones? Fantastic question. Very insightful, but you're 100% correct. I would say of all the herniations I treat with laser endoscopic surgery, all my surgeries that I do, I would say 90% of them are contained disc herniations. That means they're small. Okay, so these are small herniations. They're not ginormous. They're not causing mass effect. Mass effect means crushing the nerve root. So they're not causing mass effect on the nerve root. So 90% of the surgeries I do for pain in the back and legs or neck and arm is for smaller type herniations. So here's how they do it. They do it through inflammation. Pure and simple. Inflammation. That herniation, that jelly that's squeezed out through that tear, is so toxic to the inflammatory system. It promotes a massive inflammatory response. And that inflammation is painful. If you don't know what I'm talking about, just remember when you had pimples. And if you took a really swollen pimple and you stuck your finger on it, it hurts. It hurts like hell. So that's really what you're feeling down in your lower back is a pimple in your herniation, in your disc. And that little pimple is what I go in and shave down with the laser. I get rid of the material inside the disc pimple. Let's call it a disc pimple. We're coining a new term here. But for those of you who are writing with us today, we just made history. We now have something called the disc pimple. So that's really what we're dealing with is a little inflamed area in the disc from a small herniation. Doesn't have to be big, but boy, can it cause a lot of pain. And that's because of inflammation. So that's why little guys cause so much pain. All right, next question. Somebody writes in and says, I have chronic back pain in my thoracic, but when I lay down, I have no pain at all, even when twisting and turning. Why is that? Great question. The fact of the matter is the spine itself is a biomechanical structure. It's designed to bear weight. So anytime we load it with weight by standing up or carrying things, it puts force straight down the spine. So what's happening is when you're standing up, you're actually loading your discs and your joints. You're basically putting pressure on them. It's because you got to think about the weight of your head and your arms and your organs in your chest cavity, like your heart, lungs, etc., blood vessels. They're all pushing down, putting weight on your spine, your thoracic spine specifically. So it doesn't surprise me when people have spine problems that they have more pain when they're up, putting weight on their spine. Now, what is causing that pain? That's a great question, and we don't know. But it sounds like it could be a fracture of the vertebrae, like a vertebral body fracture would be common, or even a disc herniation could do that, or facet joint arthritis could do that. Those are some pretty common causes of thoracic pain. So fractured vertebrae that isn't healed, basically. So when you stand up, you're putting pressure on that fracture, and it's causing more inflammation and pain. So I couldn't tell you exactly why you have thoracic pain. Nobody in the world can unless we have pictures. The kind of pictures I need is MRI, CAT scan, X-ray, and I would love to see where your pain is. But if I had that information, I could help you and figure out why you're having so much thoracic pain. That's what we do at Duke Spine Institute. We help people figure out where their pain's coming from, and then, of course, we have the best treatments in the world available to fix pain in the spine, whether it's neck pain, thoracic pain, or lower back pain. Great question, though. That's our last question. So I'm Dr. Ara Duke-Majan. I'm the CEO and founder of Duke Spine. And it's Friday afternoon, and it's 5 o'clock in Florida, where we're located. Now, I don't feel compelled to leave because, honestly, I have nothing else in life to do but my work, and I enjoy my work. So if I could sit here and educate people a little bit more, then I'll do it. For those people who are interested in learning. And by the way, for those of you who don't know, we record all of these surgeries, so these are all going into a large video archive of surgeries that are done here at Duke Spine Institute. And every single surgery we do, we video archive. And of course, we always get patients' permission to do so. And we broadcast when patients give us permission to broadcast. So we have a massive repository now of every type of spine surgery you can do, from lumbar fusions, osteotomies, reconstructive surgery of the cervical, thoracic, or lumbar spine, done by me, of course. I'm a neurosurgeon, board certified. My specialty is spine. We have all types of spine surgery that we've been doing for the last 5 years, including Duke laser disc repairs that you watch, thoracic laminectomy, spinal cord stimulators, even carpal tunnel releases. We have all that in high definition video archived at Duke Spine Institute. We don't sell it. We don't give it out. It's for us and our doctors. So if you're a doctor and you want to be one of the best spine surgeons in the world, contact me. We'll have a fellowship available. We can do some training. You can come down and learn how to do spine surgery the proper way for patients, what's best for the patients. That's really our primary goal here at Duke Spine, is to fix people and give them their quality of life back. Zach, anything you want to add?
Off the top of my head.
Zach wants to say that he has just reconfigured our app. So for those of you who don't know about our app, go to your Apple or Android app store and type in Duke Spine Institute, and there is a Duke Spine Institute app. And I guarantee you it's going to be the best spine app you've ever seen in your life. It's amazing. It has tremendous amount of information and all kinds of stuff for you to explore. So you can learn a tremendous amount of about back pain, neck pain, conditions, and how to treat it by going to our app and downloading it. The app is free. We don't charge. I try to keep as much free as possible that we can give the public. And the purpose is education and helping people get better. And that's really what our mission is. So anytime we can do anything free, we do it. Obviously, when we say free, it's free to you. It's not free to me. I'm still paying for it. So Zach helped me create one of the best spine apps in the world, and I think it will be the best spine app in the world for a long time. We're constantly changing it and making improvements. If you have suggestions, just let us know. Leave some comment. But otherwise, if you enjoy the app, please give us, I don't know what you do, a thumbs up or however you rate the app, but please rate the app for us and let us know what you think. You can request a video conference through the app. You can have your MRIs reviewed through the app. You can learn about conditions. And we are going to be using this app very soon in our clinic when patients come in to basically document their condition and what treatment we're recommending. So again, it's got so much in it. Just go ahead and explore it. Check it out. Hopefully you'll enjoy it. And I think that's it for today. No more questions, Zach? All right, have a wonderful, blessed afternoon. And if our patient is wanting to do a video, we'll broadcast in about 30 minutes.